organizers of Mentcon 2024 for giving me this opportunity. Today I am going to talk about the role of myofunctional therapy in obstructive sleep apnea syndrome. Next 8 minutes we are going to go through these points. Myofunctional therapy is a neuromuscular re-education exercise training program for muscles around face, mouth and tongue to improve talking, eating and breathing. This myofunctional therapy is quite well established among orthodontists, but it is having a good comeback, or maybe it is strongly coming in ENT field as a treatment of obstructive sleep apnea syndrome patients. So as we are talking about myo and function, so let's go to the basics of muscle fibers. We have three types of muscle fibers in body. There are slow twitch muscles. The best example to explain these slow twitch muscles are marathon runners. Like they go on and on and on. I call it Duracell battery. Exactly opposite to it, we have a fast twitch muscles. These are 2x muscles, and these are exactly opposite to it. They deliver the burst of energy in few seconds, and so these are fast twitch muscles, and there is an intermediate in between this. These are the 2A muscles. So when we are using this exercise for our OSA patient, what we are expecting is we want our airway muscles to work on and on and on for longer duration, for our sleep time 7 to 8 hours. We don't want to make them fatigue, or we want to improve their responsiveness. So obviously we are looking for the repetitions. We are looking for the endurance of the muscles. So while giving the program or the exercises, when you plan for your patients, you have to have those program a goal oriented one or outcome oriented one. So obviously we will choose the endurance based exercises for this myofunctional therapy for OSA patient. And how do we achieve this endurance? We achieve this by doing multiple repetition, multiple times in a day and for multiple months. So that's how we achieve endurance. These are the basic of exercises. And secondly, if we exactly opposite to that, if we want to improve the strength, we have to go on to increase the poundage, like the weight you are lifting, which the burst of energy, which will give you the bulky muscles, but that will improve the strength, but the muscle will be fatigable. So here, when we are focusing on the OSAS treatment, we are looking for the endurance of the muscles. So how do we treat this, or how do we, I'm going to talk about the basic of myofunctional therapy. You can choose the exercises yourself. So this obstructive sleep apnea, when it deals with, we all know that deals with the upper airway obstruction, and here, as we know, this upper airway is a very dynamic and complex structure. Basically, it is a tubular structure with a lot of muscles around it, and it is supported by the cartilaginous and bony framework. So except the first static part of the nasal cavity, the rest of the nasopharynx, laryngopharynx, oropharynx, velopharynx, all are the dynamic structures. They keep on changing throughout the night. So when we are dealing with this, look at these muscles, all the muscles, some fibers are running oblique, some fibers are running circular, some are running longitudinal, but when they deliver or when they act to form the process of swallowing or the breathing, they are in sync with each other, and they are working like a ballet, and they don't work as a solo performance. Otherwise, the process will not happen. So when we are dealing with the OSAS patient and we are using these exercises to help them or to improve so what we are focusing on, the physiological phenotypes of OSAS, that the palm scale. So what we are going to improve, we are going to improve the collapsibility of the airway. We want the airway not to collapse, so that we want to improve the tone of the airway muscles, right? Secondly, we want to increase the arousal thresholds. We want to kind of increase the arousal thresholds. We want to reduce the loop gain so that we get the good sensitivity to the chemoreceptors, that is PaCO2, and we want the muscles to be responsive and effective throughout the night time, throughout the sleep time. So this is what we are focusing on. So how we are going to deal with it, or how we are going to do it, we have to focus on the dilator muscles of the airway. And which are the dilator muscles? The first one is the genioglossus, is the major dilator muscle. So if we achieve the good tone of this muscle, if we tone up these muscles nicely, so it will be responsive, it will be effective, and there won't be any kind of muscle fatigue later on. And the second important muscle is levator vela palatini muscle. So we are going to I'm going to explain it to you later again. So but remember all these dilator muscle. So how this myofunctional therapy works in OSAs? It improves the tongue position. Ideally, when we are sleeping, our tongue is stuck, or there is a negative pressure created in oral cavity because of the lip seal and nasal breathing. So the tongue is stuck to the hard palate actually over here, and it should remain like this throughout the night. If your genioglossus or muscles is toned up, it will remain in that position, giving the good retrolingual space for breathing, so that we are setting the nasopharyngeal airway for the patient. And then again, lip seal. If the lip seal is not there, if the air is leaking or the mouth is open, then we are not going to get this kind of a situation of the nasal breathing. Automatically lip seal, and then we will get a nasal breathing. If this everything falls in place, then the muscle will not be fatigued, they are not overworked, and so that we are going to get a good muscle responsiveness as well as the effectiveness. So this is what happens especially in the adenoid hypertrophy patients. So they are keeping their mouth open throughout the night, and afterwards what happens, the upper lip gets hypotonic, like it is not developed, it is underdeveloped. You see the thin upper lip and stout and strong lower lip. So we have to work upon this hypotonic upper lip by giving them the exercises, which exercise I am going to tell you later when I am going to describe the MFTs. So what is our goal to give the myofunctional therapy to our patient is achieve the endurance of all these muscles what I was talking about, the dilator muscles. So how we are going to achieve it? By giving I'm repeating it again and again. This is the basic principle we have to remember while giving the exercises to your patient for the OSAs. So multiple repetitions, sets multiple times in a day to be continued for days together. We don't want this situation. We don't want a bulkiness in the muscle. We don't want to make the muscle strong, but we want to make the muscles lean and thin and slim, so that they go on and on like a Duracell battery. So there are certain exercises which we can do. I'm just going to enumerate it: the tongue positions, different tongue movements, then tongue presses against the hard palate, tongue tacos. This needs to be repeated again and again. I will need 1 minute, please. And second exercise is like lip exercises. This exercise I give it to my all adenoidectomy patients who have a thin upper lip to improve the tone of the upper lip. Then there are palatal exercises. A simple pronunciation of A, 20 times, 3 times in a day for 3 months improves the strength of levator vela palatini muscle. And there are certain breathing exercises. Keeping the book on the chest and the abdominal wall, you can do this: breathe light to have a low tidal volume, like you have to achieve the low tidal volume to reduce the chemosensitivity to CO2. Breathe low, that engage the diaphragm and lower lateral ribs. Breathe slow, that is we do kumbhaka in pranayam, so that is the same fundamentals works with this to improve the chemosensitivity to CO2. And there are a lot of studies which conducted which shows that if these exercises are followed and continued regularly, it reduces AHI by 30 to 40%. And what are the benefits of MFT? It is inexpensive, it is non-invasive, there is no age restriction, it can be considered as alternative method of treatment for mild to moderate OSAs, and it can be done anywhere, any time of the day once learned. It improves the OSA symptoms, reduce AHI if done consistently for 3 months, and it improves the CPAP compliance with reduction in pressure levels also, the required pressure levels for CPAP. But the drawback is it is adjuvant therapy and not considered as a very standalone therapy. It is the adherence is as low as 30% or cannot be used for people with special needs. So the take-home message is 20 to 30 minutes of myofunctional therapy every day for 3 months reduces AHI by 30 to 40%. It is proven and there are studies. And MFT works best as an adjuvant to CPAP or post-bony framework surgery. And the adherence to MFT is as low as 30%, which needs to be improved by working on the non-adherence factor. And MFT is a new, upcoming, promising, inexpensive, non-invasive, anytime, anywhere practicable, active or passive form of treatment for OSA. Thank you so much. Yes.